Good morning, everyone. It's my pleasure to introduce Dr. Rodrigo Cavallazzi, Associate Professor of Medicine and Director of the ICU at University of Louisville. Dr. Cavallazzi completed his medical school in Brazil, 2001, and followed by training in internal medicine and pulmonary until 2004. And he came to the US, did his residency, University of Miami, followed by fellowship for pulmonary critical care at Thomas Jefferson. And he joined us in 2010, and he's been a superstar since joining us, receiving numerous awards, Faculty of the Year Award. It's almost every year from the Department of Medicine. Stellar research career. He's the director of our clinical research at the division and published heavily with Dr. Ramirez on the pneumonia and infection in the ICU. And his talk today is basically an overview of the pneumonia, which is the work that he's done over the years and published heavily regarding the pneumonia. And I'm pretty sure that the trainees and faculty will enjoy the talk and they'll learn tremendously from his talk today. So thank you, Dr. Cavallazzi, and welcome.
Well, thank you so much. I appreciate the kind introduction. It is an honor to be here and to give these grand rounds. So the topic today will be overview of community-acquired pneumonia and emphasis on the research we've been conducting here at the University of Louisville. So I am a PI for a clinical trial that is evaluating a monoclonal antibody for community-acquired bacterial pneumonia. And that is my conflict of interest. So this is the outline of the lecture. We're going to start off with epidemiology, some of the studies we did on epidemiology of community-acquired pneumonia, microbiology, severity assessment, clinical course. We'll talk about pneumonia phenotypes, and finally, we're going to talk about COVID-19. In terms of epidemiology, this was a study that was conducted here at the University of Louisville, and the title was Adults Hospitalized with Pneumonia in the United States, Incidence, Epidemiology, and Mortality. The study was conducted in all adult hospitals of University of Louisville from 2014 to 2016. It lasted for 2 years and was a prospective study where all patients with community-acquired pneumonia were admitted to one of the adult hospitals in Louisville were included. And this study included over 7,000 patients. Because we included all hospitals in Louisville, we're able to calculate the incidence of community-acquired pneumonia requiring admission to the hospital. And from that, we're able to estimate the number of hospitalized patients with community-acquired pneumonia in the United States. We found that the incidence of community-acquired pneumonia requiring hospitalization is 634 per 100,000 adults. And we found that we estimated that over 1.5 million people get admitted to the hospital for community-acquired pneumonia each year in the United States. As you can see in this graph, age is a major determinant of, as a major risk factor for admission to the hospital with community-acquired pneumonia. You can see that the number of patients grows with increasing age. And we found that the most common risk factor for community-acquired pneumonia requiring admission to the hospital is COPD, followed by heart failure. Other studies have also shown that COPD is the main risk factor for development of community-acquired pneumonia. We found that the mortality in hospitalized patients was around 6 to 7%. The 30-day mortality was 13%. And this study followed patients for a year. And we found that the 1-year mortality was 30%. This is another study that from the same cohort of patients, but here the focus was community-acquired pneumonia requiring ICU admission in the United States. So we use the same methodology, we found that about 23% of the patients with community-acquired pneumonia that get admitted to the hospital end up in the ICU. And we found that the incidence of adult patients of community-acquired pneumonia that require ICU is 145 per 100,000. And this is very shocking. This number is staggering. So the mortality for patients with community-acquired pneumonia that go to the ICU, the in-hospital mortality is 17%. The 30-day mortality is 27%. In 1 year, close to half of the patients die. Close to half of the patients die. This is a map of Louisville. And what this map shows is, on the left here, A is the number of cases according to quartile. So the darker is the highest quartile. So you see that the cases of community-acquired pneumonia are more clustered in the west of the city. So the west of the city, if you are from there, you have a 1.8 higher risk of developing community-acquired pneumonia requiring ICU admission. We also see, this is now looking at the poverty, and you see that the the highest poverty is also in the west of the city. So here we are showing through an ecological association the social determinants of pneumonia, the social determinants of impacting the development of pneumonia requiring ICU admission. We know that some of these neighborhoods here in the west, people are there's agglomeration of people in houses. There is difficulty to access healthcare. Some of these areas don't have supermarkets. They have more convenience stores. So all of this impacting the health of these patients. You can see that here in this map, you can see the poverty, and the little dots are the actual cases of pneumonia requiring ICU admission. So then, one of the shocking things of these studies that were performed is that these patients have a very high long-term mortality. So why do patients hospitalized with community-acquired pneumonia have such a high long-term mortality? Maybe because they have more comorbidities. They have more comorbidities to begin with, end up getting admitted to pneumonia, but because they have a lot of comorbidities, they have such a high long-term mortality. But the presence of comorbidities by themselves do not seem to explain this finding. For instance, this was a study performed by Dr. Ramirez and his group at the VA. And so here, they looked at the long-term survival of hospitalized patients with community-acquired pneumonia, and they compared this long-term survival with patients admitted for other causes. As you can see, if you're admitted to the hospital with community-acquired pneumonia, your survival is going to be lower. Your long-term survival is going to be lower than if you're admitted to the hospital for another reason. Let's say a cellulitis or a heart attack. So you have a lower long-term survival if you get admitted for pneumonia. And this after adjusting for other factors, for severity of disease, for comorbidities. So why is that? So this group from Pittsburgh has looked at the inflammatory markers at hospital discharge, and they found that these inflammatory markers predict subsequent mortality of the pneumonia and sepsis. So the patients who have high inflammatory markers upon discharge will have lower long-term survival. So maybe pneumonia sets up inflammation, and inflammation contributes to this increased long-term mortality. Now, moving from epidemiology to microbiology. This was a review, a systematic review we conducted before the COVID pandemic. And we found that we included studies that used molecular tests to assess for viral infection. And we found that about 25% of patients with community-acquired pneumonia have a viral infection. This is a very high number. Before the pandemic, the most common viral pathogens were influenza, followed by rhinovirus, coronavirus, respiratory syncytial virus. And this actually may be an underestimate of the true prevalence of viral infection in community-acquired pneumonia, because, for instance, 2 studies obtain low respiratory, because these studies, usually when they do these studies, they usually do a nasopharyngeal swab. But in 2 of the studies, they actually went to the lower respiratory tract via bronchoscopy. And then they found that, in those patients, the prevalence of viral infection was 44%. And then it was also high in the studies that included only patients requiring ICU admission. So it may be the presence of a viral infection may be associated with a little bit high risk of death, but the confidence interval is wide. So now we know that viral infection is commonly found in community-acquired pneumonia. It is in many studies even more common than bacterial pathogens. Here in the United States, there was a large study that was conducted, a cohort study in multi-center, that showed that rhinovirus was the most common viral pathogen. This was before the COVID-19 pandemic. The big question from the studies is the viral pathogen causing the pneumonia, or is it a bystander? That is a question, it'll be an interesting research question to look into. In terms of bacterial pathogens, I also think there might be an underestimate of the prevalence of bacterial pathogens. In many research studies, only about half of the cases we find a pathogen in community-acquired pneumonia. But I think that when we start doing molecular studies to look for bacterial pathogens, we're going to find a higher prevalence of bacterial pathogens as well. Streptococcus pneumoniae remains the most common pathogen causing community-acquired pneumonia, although the epidemiology of that is changing with the vaccination. In patients who are treated as outpatient, who do not require admission to the hospital, the atypical bacteria are very important. So atypical bacteria, intracellular microorganisms, that includes Mycoplasma, Chlamydia, Coxiella, and Legionella. So in patients who have community-acquired pneumonia who are treated in the community, the atypical pathogens are very important. Some studies show a very high prevalence of atypical pathogens in this population. In patients who get admitted to the hospital, of course, Streptococcus pneumoniae remains a very important pathogen. But also in patients who get admitted to the ICU, old studies show that Legionella is a common pathogen as well. In some old cities, Legionella was the second most common pathogen of community-acquired pneumonia requiring ICU admission. This changes according to the time period and changes also according to where the study was conducted. This was a review article that Dr. Ramirez and I wrote before the pandemic, and this is just showing, this table is just showing that this is the community-acquired viruses, so influenza, respiratory syncytial virus, human rhinovirus, adenovirus, parainfluenza, coronavirus, metapneumovirus, and Boca virus. As you can see, most are RNA virus, except adenovirus and Boca virus. And here you see some important antigenic structures, and those are interesting to look at because, there are ongoing research and development of new treatments for these viruses that are targeting these antigenic structures. For instance, the fusion glycoprotein of respiratory syncytial virus has been a target of new antiviruses that are being developed. I like to divide, when we approach viral infection in community-acquired pneumonia, I like to divide the patients in immune-competent and immune-compromised, because the immune-compromised patients, they are at risk of acquiring the community-acquired virus that we just talked about, but they also are at risk of endogenous reactivation of viruses, and those are typically the herpes viridae family of viruses. Another interesting aspect of the epidemiology of viral infection in community-acquired pneumonia is that we always think of these community-acquired viruses as viruses that you really acquire in the community. But actually, we know now that there's a lot of hospital transmission of these viruses. particularly immunocompromised patients. This was a graph that we generated, so if you have for the viral pathogen-directed therapies. So again, it's interesting to divide the patient immunocompetent and immunosuppressed. For the immunocompetent patient, we have treatment for influenza with the neuraminidase inhibitor, and for no-influenza viral pathogens, generally there's no treatment available, except of course for COVID, which we're going to talk later. But treatment can be considered on a case basis. For instance, the patient is pregnant, etc. For immunosuppressed patients, there are some data. The data is not always strong, but there are some data for antivirals. For instance, for respiratory syncytial virus, inhaled ribavirin. For cytomegalovirus, we can do ganciclovir. For varicella, herpes simplex acyclovir. And this is just showing that in patients who have influenza and are hospitalized, about 29% of these patients actually have pneumonia. Patients with influenza in the hospital, 29% have pneumonia. And out of these patients with pneumonia from influenza, 27% require ICU admission, 18% require mechanical ventilation, and mortality is 9%. This is, I find this is a fun graph that we created. This is showing the importance of learning the epidemiology of what's going on. Always be aware of the epidemiology through data from the CDC, through the local health agencies. And this is, for instance, if you use a clinical prediction rule to evaluate whether your patient has influenza. So this clinical prediction rule is just cough and fever. If you are, and then use the likelihood ratio. So the likelihood ratio allows you to assess the post-test probability of a condition if you know the pre-test probability. For instance, if the patient comes with cough and fever, and this patient is not in the season where influenza is circulating, having cough and fever only increases your post-test probability of having influenza from 0.7% to 5%. If, on the other hand, you are working the AD, you are in the front line, and there's data showing that the prevalence of the baseline prevalence of influenza patients coming to the AD is 20%, and if you have cough and fever, that increases the post-test probability to 60%. This is just showing that knowing your local epidemiological data is valuable when you talk about respiratory infection. This is another article that we did with Dr. Ramirez's group that took advantage of a multi-center database that Dr. Ramirez created. It was the CAPO database, where people from all over the world would feed in cases of community-acquired pneumonia that required admission to the hospital. So this is a truly international database. And what we did is we wanted to create a prediction rule. We always think of Mycobacterium tuberculosis as an indolent disease, something that people have cough for over 3 weeks and have some constitutional symptoms. But we know that Mycobacterium tuberculosis can cause a picture that is just like community-acquired pneumonia. Patients can come in a florid way. They can come in an acute fashion. And so we queried this database that had have close to 7,000 patients, and we assessed, the cases where the pathogen was Mycobacterium tuberculosis. Okay, and we found that those are the risk factors really associated with Mycobacterium tuberculosis as an etiological agent in community-acquired pneumonia requiring ICU admission. So night sweats, hemoptysis, weight loss, Mycobacterium tuberculosis exposure in the past, and upper lobe infiltrates. And then, it's always important to bear in mind the pathogens that may cause subacute chronic community-acquired pneumonia. That is tuberculosis, nocardia, fungi, non-tuberculous mycobacteria. So we'll move to severity assessment of community-acquired pneumonia. This was a study that we did with Dr. Ramirez's group, and Alessandro was a fellow. And we wanted to assess the current prediction rules for the need of ICU admission, wanted to improve that. So predicting the need of ICU admission community-acquired pneumonia. As you know, when patients come to the hospital with community-acquired pneumonia, it's always important to assess whether this patient needs ICU so they can get timely treatment, so they can be better monitored. And you can use clinical judgment, but the IDSA and ATS have created guidelines to help to decide which patient needs to be admitted to the ICU. So, and these guidelines came out in 2007. It has major criteria. So the major criteria is invasive mechanical ventilation, septic shock with need for vasopressor. This is obvious, right? If the patient has one of those, the patient needs to be in the ICU. But there are also minor criteria. And those are all the minor criteria here. And they say if you have 3 of those minor criteria, you need to come to the ICU. So, for instance, respiratory rate equal over 30, a PO2-FiO2 ratio equal less than 250, and so on, multilobal infiltrates, hypothermia. And so what we wanted to do is we wanted to individually assess, because the way the guidelines put forth is that, you know, they treated each of these variable having the same weight, but we thought, you know, maybe those variables should have different weights. So we assessed in a large cohort of patients the magnitude of each variable to predict the need to be admitted to the ICU, and we created a score. So we multiplied each log odds coefficient by 10, and then we created a score. And we added 2 variables, which is non-invasive mechanical ventilation, lactate more than 2. And we found that if you have a score equal more than 40, that has better accuracy than just using what the guidelines had proposed or some other models. It had better accuracy to predict who needs to go to the ICU. So this was an interesting study that we did with our fellow. So we found that this model that we created that used a score and gave different weights for each variable had a high accuracy to predict ICU admission, and it was also practical to use at bedside. Talk a little bit about the clinical course of community-acquired pneumonia. This, again, another study that we did, Dr. Ramirez group did with Paulo Perani. Paulo Perani was a faculty here. So the title of the study is Incidence and Mortality of Adults Hospitalized with Community-Acquired Pneumonia According to Clinical Course. This was a very interesting study that we looked at the clinical course of patients and the prognosis according to the clinical course of patients with community-acquired pneumonia. So this study had a very large number of patients, and we divided the clinical course into clinical improvement. And clinical improvement is if the patient had improved cough and shortness of breath, no longer had fever for 8 hours, had improving leukocytosis, and was able to take oral medications, oral food. If the patient met this criteria, the patient was classified as having clinical improvement. Clinical failure was if the patient needed mechanical ventilation or the patient was in shock needing presso. And we found that in the first 3 days, 65% of the patients had clinical improvement and 19% had clinical failure. Those are patients with community-acquired pneumonia in the hospital. Another 12% had late clinical improvement. So clinical improvement from day 3 to day 7. And another 1% had late clinical failure. And another 3% had what we call no resolving pneumonia. No resolving pneumonia is when you don't reach clinical improvement, but you also don't go into clinical failure. And we found that if you had clinical improvement, the mortality at 1 year was 23%, but if you had clinical failure, the mortality in 1 year was 51%. And those are some predictors of either clinical failure or no resolving pneumonia. You can see that the main predictor was really hypoxia. If your PO2-FiO2 ratio was equal less than 250 upon arrival, you had over 5 times higher odds of having clinical failure or non-resolving pneumonia. Other predictors were respiratory rates. So again, just doing a good physical examination, assessing the degree of hypoxia and the degree of respiratory distress will tell you the trajectory of the patient with community acquired pneumonia in the hospital. So a couple of studies on pneumonia phenotypes that Dr. Ramirez's group, along with some basic researchers here at the university, performed. This was a very interesting study, and the first author is a faculty here at University of Louisville, Dr. Fernandez-Botran. It looks at inflammatory responses in severe and non-severe community acquired pneumonia. So this study included 40 patients and classified the patients into severe community acquired pneumonia and non-severe community acquired pneumonia. And what this study showed is that if you have severe community acquired pneumonia, your systemic inflammatory markers or cytokines are going to be elevated. In other words, you're going to have systemic inflammation. You can see here interleukin-6 in the blood, much higher if you have severe community acquired pneumonia as opposed to non-severe community acquired pneumonia. Some other inflammatory markers mostly elevated when you have severe, mostly higher in severe community acquired pneumonia as opposed to non-severe community acquired pneumonia. So if you have severe community acquired pneumonia, systemic inflammatory cytokines are going to be increased. On the other hand, your lung inflammatory cytokines are going to be decreased in severe community acquired pneumonia, are going to be lower as compared to non-severe. So in other words, if you have severe pneumonia, you're going to be systemically inflamed, but your local inflammatory response, the inflammatory response in the lung, may not be enough. You may not mount a local inflammatory response. That's what this study found, and I thought that was very interesting and really hypothesis generating. And this is just showing, that the outcomes of patients with pneumonia is really dependent on several things. It is dependent on comorbidities. It is dependent on pathogen virulence and load. It is dependent on the treatment that you choose for the patient and also the inflammatory response. And based on this study, we kind of propose that maybe there are some phenotypes of how you respond to the pneumonia. For instance, phenotype A could be you have a low systemic response, so you're not systemically inflamed, but you have a good local response, a good pulmonary response. And in this case, your pneumonia is not going to be severe, and you're going to have good outcomes, as opposed to phenotype B, where you're systemically inflamed, you don't mount a local response, you develop severe pneumonia, and you have poor outcomes. And this is interesting because there are some studies showing that in many patients, you're really able to eradicate a pathogen within hours, and so, but then why do some patients go on and die from pneumonia when you're able to eradicate the pathogen within 24 hours, sometimes within 48 hours? And it has to be the inflammatory response. And in fact, there has been a lot of interest in how you can modulate the inflammatory response in patients with pneumonia. Recently, 2 clinical trials have been published. One is called the Cape Cod trial, was from Europe, and included 795 patients with severe community acquired pneumonia. It showed a significant decrease in 28-day mortality. So this is a major study published in a very respected journal that showed that if you give hydrocortisone for patients with severe community acquired pneumonia, that is patients who are requiring ICU admission, you actually have a decrease in mortality. Another study was published here, from the United States. It's called the ESCAPE trial, and this study was performed in the VA hospitals here in the United States. It did not quite show a significant improvement in mortality, but the trend was towards an improvement in mortality with methylprednisolone. The big difference between these 2 studies is that in this Cape Cod trial, the European study, the steroids was given earlier. If you actually read the studies, you find that in the Cape Cod trial, steroids were given earlier. It makes sense, right? When we give steroids for patients who have bacterial meningitis, the recommendation is actually to give before you give the first dose of antibiotic. This is just algorithm that Dr. James Bradley, one of our fellows, did, and we published in the Brazilian Journal of Pulmonology, which I'm an editor of that journal. So in patients admitted to the ICU or intermediate care within 24 hours of hospitalization or community-acquired pneumonia, if the patient has one of those, mechanical ventilation, or patients high flow nasal cannula, PO2 FL2 less than 300, FL2 equal more than 50. If the patient is using a no-rebreathe mask, or if the patient has a high pneumonia severity index score, then it'll be indicated to initiate hydrocortisone, 200 milligrams a day, preferentially within 24 hours of meeting that criteria. But you should also be aware of the potential contraindications for steroids in community-acquired pneumonia. One of them is influenza infection. And I'm not sure I buy that. During the H1N1 pandemic, a lot of people used steroids for influenza. And it showed, when they did the studies, it showed that steroids were associated with higher mortality. The problem is that those studies were observational. And when you look at observational studies, there's something called confounding, and confounding by indication. So you're more likely to start steroids in someone who is sicker. You can always adjust, but there's always some residual confounding. So to resolve that, you really needed to do a clinical trial. They were unable to do a clinical trial on steroids for influenza during the H1N1 pandemic. I think that the research community has got better. And I think that, with the COVID pandemic, maybe in the future, there might be a clinical trial. But as of right now, steroids, systemic steroids are not indicated in influenza pneumonia. Of course, if the patient is severely immunocompromised, you don't want to give steroids. If the patient has DKA, if the patient has TB or fungal infection or GI bleed, you don't want to give steroids. So talk about COVID-19. So right at the beginning of COVID-19, when nobody was, very few people were still were talking about COVID-19, Dr. Ramirez was already in communication with several people throughout the world and setting up this surveillance and the COVID-19 study. And there was also a COVID-19 clinic. I'm not going to talk much about this COVID-19 clinic, the studies that we have done on that, but that was also very cool. It was a free clinic for patients with COVID-19. I'll talk a little bit about the studies that came from this surveillance COVID-19 study, patients hospitalized with COVID-19 pneumonia. So this was a study published in CHEST by one of our fellows, Dr. James Bradley, that used the data set that was created by Dr. Ramirez with patients with COVID-19 admitted to the hospital of pneumonia. And this study looked at CUB-65 in pneumonia severity index. As many of you know, pneumonia severity index was developed here in the United States and CUB-65 in England. And those are scores to help you gauge who should be admitted to the hospital and who should not be admitted to the hospital. Patients who have community-acquired pneumonia. The pneumonia severity index is a complex system that includes age, comorbidities, physical examination findings, laboratory radiographic parameters. So it's really something that usually is computer intensive. The CUB-65 is a little bit more simple. Okay, it stands for confusion, urea over 7, respiratory rate equal of more than 30, blood pressure, the systolic less than 90, and the diastolic equal less than 60, and age over 65. And sometimes you can use another version of that removes the urea. Then you can only depend on physical examination findings and age. So these two scores systems help you decide which patient with community-acquired pneumonia needs to be admitted to the hospital. And what we looked at is how can they predict mortality in patients with community-acquired pneumonia due to COVID and due to other etiologies? And we'll compare that. So the first thing that was very interesting to find is that for every category of the pneumonia severity index. So in theory, they have the same severity of disease in each category. Look how the mortality for COVID was much higher for every category of pneumonia severity index. Look at that. If you have like, risk class 4, the mortality for community acquired pneumonia due to COVID was 21% as compared to 4% if you have pneumonia for other etiologies. The same thing held true with the CUB65. For every category of CUB65, if you had pneumonia from COVID-19, your mortality was much higher. And so this graph just shows that the pneumonia severity index predicts mortality similarly, whether the pneumonia is caused by COVID-19 or other etiologies. Same thing with the CUB65. So you can use these models to predict mortality, whether the pneumonia is caused by COVID-19 or some other pathogen. We did not find that adding D-dimer procalcitonin adds accuracy or improves the model, both for PSI and CUB65. So there's no need to add D-dimer procalcitonin to the model. And we found that the PSI and the CUB65 are similar or better than some other models that were created specifically for COVID. This is another study, that was performed by a research scholar, Dr. Dania Sheikh, that looked at the impact of having COPD in patients with COVID pneumonia, and then in patients with COPD, the impact of having COVID-19 as the etiological agent of community-acquired pneumonia. So 2 questions were asked in this study. In patients with COPD and community-acquired pneumonia, what is the impact of having SARS-CoV-2 as the etiological agent of the pneumonia? In patients with COPD and community-acquired pneumonia, what is the impact of having SARS-CoV-2 as the etiological agent? And in patients with pneumonia from SARS-CoV-2, what is the impact of having COPD? And so just to answer the first question, in patients with COPD and pneumonia, what is the impact of having SARS-CoV-2 as an etiological agent? The answer is huge. The answer is huge. So your in-hospital mortality goes up by more than 7 times if you have pneumonia if you have COPD, and if your pneumonia is from SARS-CoV-2 as opposed to other etiologies of pneumonia. And if you have community-acquired pneumonia due to SARS-CoV-2, what is the impact of having COPD? It does increase the risk of death by 47%. This is another cohort study that was conducted with the same, the database that was created by Dr. Ramirez and his group. And it looks at acute respiratory syndrome and time of weaning off the invasive mechanical ventilator among patients with COVID-19 pneumonia. So this study included 219 patients with COVID-19 pneumonia that got admitted to the ICU. So all patients who got admitted to the ICU with COVID-19 pneumonia. And we found that the time to death or discharge from admission was 14 days, so huge. Patients end up staying in the hospital for a long time. The time to death tracheostomy or weaning from intubation was 8.8 days. In patients with COVID-19 pneumonia who are in the ICU, about a third developed septic shock, half develop ARDS, 27% have a cardiac event, and then in-hospital mortality was 20%. And here is just showing, what makes it difficult to get the patient off the ventilator. And of course, if you are inflamed, if you have an interleukin-6 that is high, you're less likely to come off the ventilator. And if you have comorbidities, you're less likely to come off the ventilator. And if you have hypoxia, severe ARDS, that's the same. This was an interesting study that the first author, Jeffrey Spindle, he was a resident physician here. He did the study together with Dr. Ramirez and myself and his group. He did the study while he was a resident physician. And I remember that we had like several meetings to get that completed. And he's now a cardiology fellow at UK, I believe. So here, what we did is we did a case control study. And we wanted to a lot of patients who had COVID-19, we knew the mortality was higher, but we also knew that many patients came from nursing home. Many patients have advanced directives of, do not intubate. What if we completely adjust for that? And then we have a good feel as to how bad COVID-19 is. So what we did is a case control study. We matched these patients for nursing home residency. You see here the same number of the same percentage of nursing home residents in the group who had influenza cap versus COVID-19 cap. So we wanted to compare pneumonia from COVID-19 with pneumonia from influenza after completely adjusting and matching for some risk factors for mortality. The main one, in my opinion, being nursing home residents, which a lot of patients with COVID-19, I don't know if you all remember, they came from nursing homes here in the United States. So we matched the patients for nursing home residency. So in each group, we had the same proportion of patients coming from nursing home. We matched for age, we matched for age, for gender. And we found that having pneumonia from COVID-19, if you have pneumonia from COVID-19, from SARS-CoV-2, you have over 4 times higher risk of dying as compared to pneumonia from influenza. This is another study. This study was performed by a research scholar, Dr. Shebo Ali. He's now a resident physician in an internal medicine program, academic internal medicine program here in the United States. And again, using the cohort that created with the Dr. Ramirez and his group, we looked at the impact of cardiovascular complications as a driver of mortality in patients with SARS-CoV-2 pneumonia admitted to the hospital. So we found that, so this had a large number of patients, 1,645 patients. We found that about 18% of these patients will develop a cardiovascular complication throughout the hospitalization. Once you have a cardiovascular complication, you have a mortality of 45%. So the mortality, almost half of the patients die once they develop cardiovascular complication. If you don't have cardiovascular complication, if you don't develop cardiovascular complication, your mortality is going to be 13%. So this is just showing the impact of developing a cardiovascular complication if you have COVID-19 pneumonia. And why these patients develop cardiovascular complication? Multiple reasons. They can decompensate the underlying cardiovascular disease. We see that all the time. Patients who have chronic AFib and then develop rapid ventricular response, or have chronic heart failure and they decompensate. We know that patients with COVID-19 is a thrombogenic disease. We know they develop clots. I mean, I cannot overemphasize the importance of venous thromboembolism in these patients. Many patients develop venous thromboembolism, ischemic stroke, myocardial infarction. They can also develop cardiovascular disease from the inflammatory status. Some patients are highly inflamed that develop COVID-19, and they can develop stress-induced cardiomyopathy, again, arrhythmias, type 2 MI. Some patients, particularly the patients who developed severe ARDS and are on the ventilator, they will develop acute cor pulmonale. The right ventricle is going to go in failure. We see that all the time now that we do point-of-care ultrasound. The virus itself can have a direct effect on the heart. Some patients will develop viral myopericarditis. And then the medications that these patients receive, particularly early in the epidemic of hydroxychloroquine and antibiotics, etc., they can develop torsades. This is a review article that we are writing right now, and it's going to be published in Clinics in Infectious Disease. And this is just a little updated summary of the epidemiology of COVID. COVID-19 worldwide has caused over 7 million deaths. The risk of hospitalization during the Omicron period, which is now, is 1.9%. So the mortality risk in hospitalized patients in the early Omicron period was 13.1, and this has gone down to 4.9. As you all know, the risk factors for mortality are increasing age, presence of underlying medical conditions, disability, being of a racial ethnic minority in unvaccinated status. I cannot overemphasize the importance of vaccination to prevent death from COVID-19. Unvaccinated patients, the mortality of unvaccinated patients is, if you get COVID, okay, and you're not vaccinated, you have a 5 times higher risk of dying compared to someone who just got one monovalent booster, okay? But you have 14 times higher risk of death, of dying, compared to someone who got bivalent booster. And this is recent data. I'm not talking about data that at the beginning of the pandemic. So please advise your patients to continue to get vaccinated. This is a review article that I wrote to Dr. Ramirez, how and when to manage respiratory infections out of hospital. And I mean, I'm sorry, this slide got a little busy here, but this is just summarizing the approach to community-acquired pneumonia if you're treating this patient in the clinic. So look at some basic information like vital signs, confusion, respiratory rate equal over 30, your blood pressure, if your blood pressure is low, your age, your respiratory rate, if it is over 125, if you are hypothermic, or if your temperature is over 40 degrees Celsius, if your oxygen saturation is equal less than 92, or if you have some important comorbidities. If any of this is present, you should try to go further to assess, does this patient need to be admitted to the hospital? You can use your clinical judgment. You can use hypoxia. Hypoxia is a potent, is a powerful predictor of bad outcomes. So if your oxygen saturation is equal less than 90, you can use this version of the CURB 65 that only look at the clinical parameters, CRB 65, or you can use the pneumonia severity index. And if you have one of those that indicate the need for admission, yes, bring the patient to the hospital. If not, I think we are in an era that if you're going to treat a community-acquired pneumonia, I think it's interesting to test for influenza and SARS-CoV-2 in every patient. And if the patient tests positive for influenza, but the patient does have pneumonia, because influenza is one of those viruses that tend to be associated with bacterium, particularly Staphylococcus, Haemophilus, and Streptococcus, I suggest that you give antiviral plus antibiotic. Now, SARS-CoV-2, usually patients, when they present with SARS-CoV-2, they usually don't have bacterial co-infection. The rate of bacterial co-infection has been quoted as about 8%, maybe even lower. Now, these patients will develop bacterial infection or other infections when they come to the hospital. They have severe SARS-CoV-2, they're getting immunosuppressive medications. Almost invariably in the hospital, eventually these patients will develop superimposed either bacterial fungal infection. But in the community, when the patient is presenting to you first time, very unusual for them to have bacterial co-infection. So if you are treating a patient in the community and you find that the patient has SARS-CoV-2, just pathogen-directed therapy against SARS-CoV-2. And if you are negative for SARS-CoV-2 influenza, just antibiotic treatment. And the antibiotic, right now, if the patient has comorbidities, we go with augmentin plus macrolide or doxycycline. No comorbidities, amoxicillin plus macrolide or doxycycline. If you're dealing with a patient who calls you, hey, I got COVID, try to triage these patients for some parameters that predict badness. And what are those? The patients tell you they have a lot of shortness of breath. That is a red flag there. You know, it means that probably this patient has pneumonia. A lot of patients nowadays, they have a pulse oximeter at home, so people can debate as to whether they are accurate. But, you know, the patient has it, just ask them to look at the oxygen saturation. So if the oxygen saturation is equal less than 94, and the patient does not have underlying hypoxia, that is a red flag. If the respiratory rate is high, that is a red flag. If a family member is telling you that the patient is confused, that is obviously a red flag. So if you have any of these red flags and you're dealing with the patient, you know, the patient call you the clinic, just you have to bring the patient for in-person visits. If the patient does not have any of these red flags, I think it's fair game to try to treat this patient via telehealth or remote visits. And then to decide whether the patient should get antiviral, you have to look at age. Age is probably the most predictor, the most powerful predictor as to whether things are going to go bad here. So if the patients, I put here age equal over 65, but the NIH has updated age over 50. If the second thing, have you got your vaccines? So the antiviral directed to SARS-CoV-2, there was a study that showed the benefit even if you are vaccinated. But of course, if you're not vaccinated, then you're even more likely to benefit from therapy against SARS-CoV-2. And then, of course, some risk factors, BMI equal more than 30 or some comorbidities. If the patient has any of these, the first choice right now to treat SARS-CoV-2 is ritonavir booster nirmatrelvir. This is a antivirus that that acts in the protease. So the virus needs the protease to replicate. Okay, so this is the first therapy. The problem with this medication is the ritonavir component interacts with a lot of medications. Nowadays, the electronic medical record EPIC will tell you if the patient is in EPIC. The EPIC will tell you what medication the patient is using that interacts. But there are some interesting websites that will help you. I go over the list of medications the patient has, and I cross with the ritonavir booster nirmatrelvir to see if there's any interaction. If there's interaction, the interaction is important. Sometimes you have to hold the medication the patient has been taking just temporarily while the patient receives the antivirus. We have been seeing some case of rebound SARS-CoV-2 for patients who receive this medication, but usually the rebound is not clinically significant. Patients get a little sick, but they still do better. This medication is highly effective. It has substantially decreased the need for hospitalization in patients with SARS-CoV-2. So if the patients have risk for progression of disease, I'll go ahead and give this medication if the disease has been within 5 days. Other alternatives, molnupiravir acts in the genome of the virus. The problem with molnupiravir is the efficacy is not as good. It also can cause fetal harm. So gotta be very, very careful in women. Even in men, they have to use protection, if I'm not mistaken, for 3 months after taking this medication. We haven't using that much. Remdesivir acts in the transcriptase. The problem for remdesivir is that it is an infusion. You have to go to an infusion center. Obviously, not very, makes the logistics difficult to treat patients of outpatients of SARS-CoV-2 remdesivir. And then there's some monoclonal antibodies as well. But the take-home message here is the long-term mortality in patients with chronic acquired pneumonia is very high. If you end up in the ICU, the long-term, the 1-year mortality is 50%. Respiratory viral infections are common in chronic acquired pneumonia. We saw that. The severity assessment can be improved with prediction rules. There are different inflammatory phenotypes, and the local and systemic inflammatory response may be different. And in the ongoing COVID-19 pandemic, we talk about PSI and CUB65 as predictors of mortality. We talk how the COVID-19 has a much higher mortality than other viruses such as flu, and we talk about the importance of cardiovascular events in COVID-19. So there are some ongoing projects that we're doing with the group of Dr. Ramirez, community acquired pneumonia, immunocompromised patients. We now know that about 20% of the patients who have community acquired pneumonia and are hospitalized have a immunocompromised condition or immunosuppressed, and with all these biological agents and our ability to treat cancer and cancer becoming chronic disease sometimes, and the other treatments for autoimmune disease and transplant, being immunocompromised is becoming exceedingly common when you're dealing with patients with pneumonia. And really, there isn't a lot of data on how we should treat these patients. We also look at the role of artificial intelligence in management of pneumonia. We are participating in multi-center clinical trials. We're developing clinical prediction rules. So acknowledgement, Dr. Julio Ramirez, he started as my mentor in 2013. He says this move to collaboration, I think he's still a mentor. We developed international database on pneumonia, created an epidemiological unit where you have epidemiologists, bioengineers, statisticians, research scholars, and has mentored several junior faculty, resident physician fellows. Dr. Forrest Arnold has always been extremely supportive, and we collaborate in many projects. Dr. Ruth Carrico, she's an epidemiologist that is also helped with many of these studies. Two statisticians, Stephen Fomanek and Thomas Chandler, we've been doing a lot of studies together. Dr. Mohamed Saad, our Chief of Division Pulmonary, has been very, very helpful as well. Dr. Sharia Kurana, she's a research scholar. Dr. Andreas Vega, she's a research scholar. Dania Schick, a research scholar. They all have been helping. Dr. James Bradley is a fellow who has been very active, has conducted many studies, and research associates in the infectious disease division as well. Thank you.
Thank you, Rodrigo. It was great, great presentation, and fantastic work that you have done with Dr. Ramirez and looking into all this database that Dr. Ramirez created. Just want to probably touch again on the COVID-19 and the mortality. From what you're writing right now and what you're seeing, because people are still doubting about the vaccine and efficacy. Can you mentioned this in your talk, but you probably another reminder about that and from your own experience.
I mean, it's hard to talk about personal experience in vaccine because it's one of those things that you do. It's like, you know, when you're in the ICU and you do a good job and you prevent a patient from, you intubate a patient, you prevent the patient from dying that night. But that type of work never gets credit because, you know, people don't realize that you actually prevent the patient from dying by intubating the patient. It's the same thing with vaccine. The patients get the vaccine, they don't die because they get the vaccine, but people don't realize individually that, you know, I think that is one aspect of the vaccine. I think it's difficult for people to understand. Another thing, it's a risk-benefit analysis. I know vaccine has been politicized, but in the end of the day, it's a risk-benefit analysis. And the patient really needs to be well-informed to make the risk-benefit analysis. You know, for instance, I have many patients in my clinic with severe COPD, and they have other comorbidities. Sometimes they're immunocompromised. And I ask them, have you got the vaccine? No. And I was like, I almost like fall. You know, I was like, why you're not getting vaccine? If anybody's gonna benefit the most from the vaccine, it's gonna be you. You're gonna be the benefiting the most, not a young person who is giving misinformation in the internet, who doesn't have comorbidities. That person maybe gets COVID and not gonna, but you're gonna die if you get COVID. So a risk-benefit analysis is very important. The patient needs to be well-informed. And I think there's a lot of misinformation out there.
I agree. We probably have some, maybe a couple of minutes for other questions. Anybody has any questions for Dr. Cavallazzi?
I'm using microphone, Dr. Cavallazzi. There's a couple of questions in the chat area. One's actually from Dr. Dryden in GI. He wanted to know regarding the Cape Cod versus VA study, were there differences in the number of patients receiving enteral nutrition?
I don't know. I would have to go back to the study. Apologize. But that's a good question. I know our GI division is very strong, and I know they do a lot of interesting studies. And I always tell the residents, you know, that our GI folks, they are very adamant that our patients need to receive enteral nutrition early on, because, you know, they feel that this really improves outcomes. And I think there are some observational studies in patients with liver disease that show that correlating the amount of protein and calories that you take and the outcomes. So I know how they feel about that. And I usually tell them, hey, let's follow what our GI faculty teaches here.
And one more from the chat area. It's from Dr. Emmons and oncology in the BMT group. He said, can you comment on steroids with other specific blocking antibodies such as IL-6 blockade, tocilizumab or serlimumab for COVID and other severe pneumonia in the ICU? Is there data to suggest a difference in immunocompromised and normal immune patients?
Okay, so first of all, in patients with COVID-19, okay, so I think the British, the England, they were able to take advantage of the national health system, and they were able, really, they got this huge clinical trial that showed that dexamethasone improves the outcomes of patients with COVID-19 that are hospitalized. And I did not talk about that, and I'm glad that I'm able to do that. It really was a remarkable improvement in mortality. It was a huge study. It was replicated by other smaller studies, even performed in other countries down the road. But there was, you know, it was really a game changer when it comes to COVID-19. Because, you know, we think that COVID-19 is this weird infection where it sets up this inflammatory response. And what is interesting is that the main benefit really came for patients who are mechanically ventilated and patients who are requiring high level of oxygen. And I think that COVID-19 is different from severe community acquired pneumonia. Severe community acquired pneumonia, you really have to start steroids early on. Here in COVID-19, it messes up your immune system as time goes by. So much so that a lot of patients start getting worse day number 10. You're not out of woods until like 2 weeks after getting COVID-19. It corrupts your immune system. And it does that late in the process. So the main benefit of systemic steroids really comes for patients who are very sick, who are who are in the ICU, who are on mechanical ventilation or requiring high flow nasal cannula. On the other hand, remdesivir had a very modest benefit for hospitalized patients with COVID-19, but the benefit is like patients, remdesivir being an antivirus, the benefit is more like early on. And then we have some other inflammatory modulators, the medications that target the interleukin-6, tocilizumab, baricitinib, the Janus kinase inhibitors. Those medications should be used as an add-on, you know, if the patient is very sick despite steroids. Now, I think Dr. Emmons' question was, if you're already immunosuppressed, that is an issue. I'm not sure the answer for that. You know, if you're already immunosuppressed and you come with COVID-19 and you already have underlying immunosuppressive condition, let's say you are taking methotrexate or you took a chemotherapy, are you still going to benefit from steroids? I'm not 100% sure about that. I think you definitely want to be in the lookout for superimposed infection. These patients will develop superimposed infection when they are in the hospital. They will develop bacterial infection, particularly if they go to the ventilator. They'll develop aspergillus. They'll develop mucorales. So you're definitely going to be doing surveillance cultures and be on the lookout for superimposed infection. If you already have underlying immunocompromising condition, and on top of that, you are put on these medications.
All right, and one more, as I know we're past 9 a.m., but Dr. Gauhar had a question. He says, any comments about the new RSV vaccine, its safety, indications, and whether it will be standard of care?
Yeah, so I haven't reviewed the literature on that. I've been vaccinating some of my patients, but I don't think I'm able to provide that type of data for him right now. I apologize, but you know, I think maybe another lecture.
Thank you, Rodrigo, very much. We appreciate your time, and it was very informative. Appreciate it. Have a good day. Thank you.